faces during COVID-19. The first one is the Bangladesh. We already know that Bangladesh is a lower middle income country. The per capita income of Bangladesh is $1,250. So we have challenges. We have faces several challenges when we are dealing with the COVID-19 pandemic situation. After that, we have world's densest population. And we are working with minimal resources. And after that, there is no specific medicine are available to treat COVID-19 till now. There are several suggested medicines that are used for the treatment of COVID-19, but there is no specific medicine that are available or that came to our research that is fully curable for COVID-19. And there is no vaccine is available. Currently, 176 companies of different all around the world have been working for development of this vaccine, but till now no vaccine is available to cure COVID-19, including Bangladesh. Globe Biotech is also working on developing a vaccine for COVID-19. The another challenge of our lower number of tests to detect the newer cases. I have already mentioned that in the last 6 months we did 21,40,129 tests to diagnose or to identify COVID patient. Among them, there are 62 PCR labs all around the Bangladesh that have the ability to perform PCR to detect COVID patient. Among 61 PCR labs, 32 are located within the Dhaka, and the rest of the laboratories are located outside the Dhaka. After that, lack of awareness amongst the people there, and initially there was shortage of personal protective, and due to COVID-19 situation, unemployment is increasing, and there is also post-COVID complication. And these are the measures that has been taken by the government to have stopped any kind of mass gathering, and there are some non-therapeutic measures that have been taken by the government. So hope to meet you all in a COVID-free world in the next conference. Till then, thank you all from Bangladesh.
Thank you very much, Dr. Nazneen Akhtar ma'am, for share a very informative speech with us. Now, I would like to welcome Dr. Pramendra Prasad from Nepal. Please welcome Dr. Pramendra Prasad.
Hello everybody, good evening from Nepal. So, can I have my slides please? Yeah, thank you. So I'm going to deal with COVID-19 status in Nepal, its rewards and challenges. Next slide, please. So, I am Dr. Praveen Prasad Gupta, Associate Professor, Department of General Practice and Emergency Medicine, BP Kerala Institute of Health Science, Dharan, Nepal. Next slide, please. I'm going to tell you about the first case which was seen in Nepal on January 13, 2020. A 32-year-old man, a Nepalese student at one University of Technology, one China, with no history of comorbidities, returned to Nepal. He presented at the outpatient department of Sukaras Tropical Infectious Disease Hospital, Kathmandu, with a cough. He had become ill on January 3, 6 days before he flew to Nepal. He indicated no exposure to the so-called wet market in Wuhan. Throat swabs obtained from the patient tested positive for 2019 COVID on real-time RT-PCR assays, and the sample was sent to Hong Kong in a WHO laboratory in Hong Kong, because at that time there was no any PCR testing in Nepal was done. Next slide, please. So the first case of local transmission was confirmed on 4 April in Kailali district, and the first date occurred on 14th May. A countrywide lockdown came into effect on 24 March 2020 and ended on 21 July 2020. Next slide, please. In the third week of March, Nepal began to see a significant influx of people from India as India saw increase in new cases throughout the country. A noticeable outflux of people from the Kathmandu Valley was also reported. The second case was confirmed on 23 March in a young woman who had recently flown to Kathmandu from France via Qatar. After that, 6 additional cases had been recorded in people. The first tests inside Nepal were conducted at the Biosafety Level 2 labs of a National Public Health Laboratory on 27 January. And till now, there are 40 different laboratories across the country who are doing PCR tests here. Next slide, please. So this is the map of Nepal, and you can well see the number of cases in the different districts, and you can see the number of cases in the lower part of Nepal because it is very close and open border with the India, and most of the people came from India as the number of cases was increasing in India. So you can see a significant number of cases over here. Next slide, please. The current scenario till 15th October 2020, there is a total cases of 1,17,996. The total infected cases are 36,367. The recovered were 80,954, and the death were 675. The total PCR test was done at 12,21,038. There is 36,367 people in isolation, and 46,066 people is still in quarantine. Next slide, please. So this is a male and female ratio. So in the total cases of the male is 82,198 and female is 35,798. Next slide, please. So we have got 5 provinces here. Province 1, Province 2, 3, 4, and 5 with Bagmati, Karnali. And this is the number of cases distributed in a different province here. The most of the cases are in Bagmati, as the capital of the city is in Bagmati, Kathmandu. And then it is in Province 2. The Province 2 is very near to Indian border. So that's why the second number of cases with Province 2 and Province 5. Province 5 is also another province which is very nearly attached to the Indian border. Next slide, please. So this is the age-wise distribution of COVID-19 cases, and most of the person who infected was a young people with 21 to 30 years and 31 to 40 years. Next slide, please. This is the total recovered and total active and death percentage. The total recovered percentage is 68.61%, where total infected is 30.82%, where death rate is 0.57%. The current scenario of Nepal is like we have got a increasing number of cases day by day from last 7 days, and we are lacking ICU bed and oxygen bed in most of the hospitals who are dealing with the COVID-19 cases. Now the challenges over here is that insufficient resource and poor healthcare systems, because most of the part of the Nepal are in rural areas. It's most of the hilly and Himalayan region where the healthcare are not up to mark. Poor human resources, there are heavy workloads to the staff, there is poor supervision and less support from other sectors and the say from government sectors, one healthcare worker have to work for a long hours. There is very less remuneration and unfair pay and no rewards. Next slide, please. Now, what authorities can do is for the shift, we can make it a flexible shift. The government has already been ordered to do a pool system duties. So most of the places the person is doing pool system duties, but in every healthcare system there are no sufficient manpower that a person can still do a pool system duties. So there must be a sleep hygiene which is facilitated by wise shift cycle and good possibility of undisturbed sleep. There must be a social support to family members. Worries for family members could add to a caregiver deterioration in health, and participation in decision making is must. So if we can give extra remuneration or extra incentive to a healthcare worker who are working in a COVID hospital or who are dealing with a COVID-19 patient, I think that will be very, very benefit for our healthcare workers. With the challenges of like there is no drugs, but we are still using remdesivir and we are still using convalescent plasma therapy. And in most of the cases, it is benefit, whereas in significant number of cases, we haven't seen any significant by giving remdesivir and conventional plasma therapy both. Next slide, please. So that was from the perspective of Nepal. Namaste and thank you.
Thank you very much, Dr. Pramendra Prasad, sir, for share with us COVID-19 present scenario in Nepal. Thank you, sir. Now, I would like to invite Dr. Kinle Bhuti from Bhutan. Please welcome Dr. Kinle Bhuti.
Hello, good evening to everyone. Welcome to the 17th World Health Rural Conference, Dhaka. Uh, I am Kilebuti. I'm a final year GP resident. So I'll be representing my country to talk about the country challenges and updates. So firstly, to begin with, to tackle this global challenge, we have His Majesty the King in the front line, motivating us, followed by our Prime Minister, who is also a doctor, and the health workers. The monastic body is performing their rituals to keep the COVID-19 at bay, and all the health workers and all the volunteers. So talking about the caseload in the country, we have, as of today, 11 a.m., we have 216 confirmed cases, of which like almost 99% of them are recovered, with 18 active cases, and fortunately, we don't have deaths as of today. It's a small country, so the first cases detected in our country was on 6th of March when one of the American tourists tested positive on 6th of March. And then the whole preparation for the COVID pandemic situation came into action. However, we were so lucky in keeping COVID-19 at bay that it was only 5 months later, on 11th of August, that we had our first community case detected in the southern part of the Bhutan, which the part shares a close porous border with India. So to tackle this global pandemic, His Majesty, on His Majesty's command, we have opened flu clinics, temporary flu clinics, shelters all around the country, like also known as respiratory illness clinic, which is settled away from a well-established hospital to keep the hospital safe from contamination by COVID-19. The flu clinics were set up away from all the health care facilities. So of total, we have 54 flu clinics across the country, away from all the main hospitals. Most of these numbers are in the southern border, which shares our border with the Indian government. It's manned by doctors, nurses, and laboratory technicians. We have like 6 labs testing for RT-PCRs. It's a small country, so we have like 6 numbers, which is a big number for us. And to talk about the high-risk regions in our country, uh, the regions as shown in the map shares a porous border with Indian government, as India has the second highest COVID caseload in the world. So that region which shares the border with India is considered as high-risk region, and they are under a strict quarantine protocol. So if anyone wishes to travel, then these are the protocol put forward by the government, that to travel from high risk to low risk, they must register. And then if it's like non-emergency, then they should compulsorily undergo 7 days of quarantine at a government facilitated free of cost facility quarantine. And if it's emergency, then they are tested with RT-PCR and then released on the same day. And then there are various new normal being put forward by country, that they can travel, but with the passenger capacity should be half of the normal capacities. And even the taxis, which usually carries 5 passengers, are limited to 3 passengers. And even the restaurants were opened with 50% of its uh, customers. So there are various testing protocols. All incoming people, Bhutanese or foreigners, are tested free of cost by the government. They are tested for RT-PCR on the 3rd day of arrival to the country, on the 7th day, on the last 22nd day. And for your information, our country, Bhutan, is the only country in the whole world that has 21 days of compulsory quarantine at a government identified facility quarantine, which is free of cost. All the cost is borne by the government. So the new normals being put forward, that is when our country first detected the first community transmission case on 11th of August, our country went under a national lockdown for 3 weeks, and then to curb the contact tracings and all. So from the 1st September, it started the new normal. That is, all schools, high schools were open, all offices were to be kept open, with the new rules that one must not go out of the house if it's not necessary. And then the mandatory use of face masks at all times, and the maintenance of the physical distance. And the government also kept, they made an app called Druk Trace, which like we need to use the app on entering any public cases, public places, hospitals, or public transport. And then there is a hand washing facility in front of every public places. So so in view of the hand washing thing, the hand sanitizer was also distributed free of cost by the government. And in the picture, you can see our Prime Minister distributing the hand sanitizer. And then use of face mask is made mandatory. All the school goers are to use these face masks, and their classes are to be in shift wise, so that the classrooms are like half kept empty, to maintain the 1 meter distance. So various antigen testing protocols are put into action by the government, that we have to go do like a rapid antigen test. If it's negative, then we release. So at the flu clinic, whoever presents to the flu clinic, they have to mandatorily undergo the rapid antigen test. If they are negative, then we release them. If they are positive, then we keep them in the holding area identified by the government at respective like few kilometers away from the flu clinics. And then they're tested by RT-PCR, and then even the close contacts are traced and tested, and then they are released only after the test comes. And if it's positive, then they are shifted to the isolation facility identified by the government, and all the necessary treatments and everything is done by the government. So for the management of the positive cases, be it asymptomatic or symptomatic, they are shifted to the government identified isolation wards across the country, manned by doctors and nurses on shift basis in a full PPE, and necessary investigations are provided whether they have symptoms or not, and then they are taken care free of cost. And if they are symptomatic, they are shifted to the COVID ward equipped with ventilators, that also away from the main hospital. And then a doctor is always there on a duty and who does a teleconsultation if he needs expert opinion. And so far, luckily, we didn't have any cases who needed a ventilator, except for the first case, that was the old American tourist who was like, he had multiple comorbidities and his age was 75. So it was really difficult to for him to manage, because he was only one patient that required all ventilators and all. So far, the youngest patient reported in our country is 1.5 years. So this all. So depending on if there's asymptomatic, we just keep them under observation in a government identified facility, and if they are symptomatic, then accordingly treated with the international protocols. Thank you. Stay safe.
Thank you very much, Kinle Bhuti, for your very much. Thank you very much, Dr. Kinle Bhuti, for share with us COVID-19 present scenarios in Nepal, sorry, in Bhutan. Now, I would like to invite Dr. Pratyush Kumar from India. Please welcome Dr. Pratyush Kumar. Can you hearing? Pratyush Kumar.
Well, if Potus is not, Gobit can go with. Invite Gobit Ratnam from Sri Lanka.
Okay. Okay. Now I would like to invite Dr. Govit Ratnam from Sri Lanka. Please welcome Dr. Govit Ratnam from Sri Lanka.
Yeah, welcome everyone. This is Govind from Sri Lanka. I'll share my slide. Mm. So, good afternoon, everyone. So I'm going to present about how Sri Lanka managed the COVID-19 and how we overcome the challenges. So basically, I'm currently coordinating the COVID preparedness and response. Just even 2 minutes before I'm in the call with another 3 positive cases. So I'm in tends to present this one as well. Luckily, I got my colleague to pass the responsibility. And as well, I'm the family physician lecturer in the Department of Community and Family Medicine University at Jaffna. From the update today, today 4 p.m. Yes, today 4 p.m. Just half an hour before, we have 5,427 patients of the confirmed cases. At the moment, on the medical care 2019, up to now, we had a 13 death. From the history, the first case of actually this imported from one of the tourists from China, diagnosed confirmed in the 27th of January. Even there's a big gap. Then we got a first local case in March 11th. So one of the tourist guy has a positive on in 3 months back. And this is a current situation of the map. Actually, we are about to get the second wave. Like from the 10 days back, we got a search of the second infection, maybe from the factory workers and all. I think it's coming down currently. This is a Sri Lanka map from the how the red colors are mentioning here is a high risk area where the last 14 days had cases. So from the Sri Lanka point of view, we are the small island country with a 22 million population, and from that, around more than 70% are living in the rural part of Sri Lanka. Also, we have the great network of primary health care, like public health system. So from that, we are able to tackle this COVID challenges in a great way. So from that, because also it's an island country, so we don't have the borders, so it's easy for to lock down from the other countries, but still from the airport and port. So that also we have get a limited in-flight and ships. So even the airport has a good quarantine facilities and all the screening setups. So from that, from the community, so we have a lot of measures has taken with our support of public health officials. From that, we have our key factors are three things. From that, I can say from the contact tracing. So when the positive comes, even the first and second contacts are contact through that and found that accordingly we are doing the adequate testing facilities. Like WHO say, we test. So that likewise we from the community, even the first, second, maybe if we needed the context, as well we do the repeated test maybe with the normally 5th day and 14 days as well. Whoever found to have positive anyway taken away the hospital for the treatment wise, who are the contacts are, always we are keeping in the or state run facilities for the 14 days. Even before they are releasing to the community, we do the test. Then even though another 2 weeks, we will keep in the home quarantine with the support of the public officers. So this is our community setup, and additionally, so all the community has always empowered and engaged and enforce the COVID things. This is a community setup. Then because of the new disease, all the institutional, hospital and healthcare facilities we have to modify it as a challenge. So temporary sheds are maybe made it, and maybe that for the triage we have differently made with the kit, maybe with the protective equipment. Even the seating facilities we should have with the adequate space and all. Also, so when we examine the patient, if they are respiratory with the symptom with the symptomatic patients, we will keep it in the separate with the glass boxes, and we'll do the first part of the history taking. If we really want to examine, so we will take it into with the protective equipment. Also, the non-respiratory patients maybe with the proper, where we will see the like in the picture. Also, because now we have to change our that normal traditional practice, because sometimes face-to-face consultation may be difficult. So we have increased our remote consultation. So this also for the challenges for us, but still we have managed with that, because one of our telecom providers given the free of charge to the public, even though from the ministry has given the app for the application for the public, and we can even for the audio video we can contact them if they really need it. We can take to the hospital. We have the free ambulance services all around the country. As well, in the limited numbers we will do for the home visit with the all adequate precaution. The other thing, so already we practice infection control measures. When you come for the in-treatment facilities or isolation facility, we should have the proper infection control measures. We always have a good thing like this. I have just shown the pictures about this red zone, green zone, and yellow zone, as well with the disinfection part like that. So this is I have shown how we manage that, but how we prepared ourselves. So previously I had told we got a first patient in 27th of January. Even just 2 days before, we had a provisional meeting. Are we ready to face it? So it was success. We have ready for that. So then we have managed. In the meantime, we had a lot of local and international collaborative meetings. Also, we have got a interim guideline for the Sri Lankan family vision about the COVID-19. Also, I am the proud contributor for that as well. Also, we got a infection control manual. These are all with a short period, we are able to manage to produce and able to achieve that. So also we did a lot of public awareness. So as usual from the Wonca part of that. So we are delivered in the own language and with the, even with the other social media, even we appear in the TV. So this is one of the of myself in the TV about the COVID updates and all. So in the meantime, so we are talking about the COVID. At the time, we have to continue the other medical conditions, especially for the chronic and non-communicable diseases. So we have made a volunteer service with the medical students about the call centers. Then we got the information from the patient. We have packed the medication and we delivered their healthcare workers in post department was involved for that. So from the challenges, so all around the world, likewise, we have the we had a very limited supply of protective personal equipments, PPE and all. Then we made it ourselves with the polythene and all. This is you can see our government hospital workers are preparing for that. Even for the we had a regional and cluster lockdown for controlling during the first phase of that. So therefore, they delivered to the goods, the foods and all. Even for the doctors, we have arranged for delivery. In addition, we have a lot of challenges with the long working hours and difficulties with this wearing the PPEs. And maybe this one of I remember, so I am shift in the morning to evening. Actually, it's extended to 10 hours. I'm fully sure 10 all. So with even pregnant ladies, with the difficult professionals are doing the great work. As well, the mental health. Mental health, of course, we should have because they are fearful with all the infectious things. We have to live with the family. So we have to take adequate rest. And this is one of the picture after one of the afternoon. I'm studying, reading the book in a peaceful manner after the heavy hectic work. So, so I has told how we manage, what are the challenges we had it, and from that actually we got a very success from the this controlling. And even though WHO and all the health organizations are praised for our and all, this is one of the WHO site, and as well with our, they have praised about this our community-based primary care system because it has done a lot for the controlling this and found the patient and keeping the. This is also again about our primary care. This is from the primary care healthcare performance initiative side. Actually, I have given this article about how we handle like that. This is me again with the coordinating center. This is up to now. So I'm in the Sri Lanka way that clip with Manak. Thank you.
Thank you very much. Thank you very much, Dr. Govit Naratnam. Now, I would like invite Dr. Pratyush Kumar from India. Please welcome Dr. Pratyush Kumar.
Thank you, everyone. And on beginning, I would like to congratulate all the organizers, especially Jakur and Bruce for organizing it so wonderfully. With this is our first virtual conference, and everyone has put a lot of effort in organizing it. And before I begin, I like to show my presentation to everyone. So here is, won't go much into the detail regarding the statistics. I'll say aspect which I'd like to discuss here. We have got around 7,95,087 cases. These are active cases. Out of that, 87.78% has already been discharged, and number is more than 65 lakhs. But we also had around more than 1 lakh deaths, and that's very important to discuss. So here I'm going to talk about one of the most important basics, which I feel is the more real issues. I'll not go much into this facts and figures. I'll go directly to these real issues. First, I'll begin with the clinical perspective. We started with lots of myths, like with the onset of winter, we'll see decline in COVID-19 cases. Uh, so many home remedies can cure. Those with BCG vaccines may not get diseases. Those living in uh, countries where influenza is very much common, those who have got influenza vaccines, they may not get COVID. Then we came into the phase of confusion, where there have been so much of controversies regarding medications, which medicines should work, which medicines won't work. Like we had with HCQS, then came remdesivir, then lots and lots of many fancy drugs came into the picture. We have also had HIV drugs. Then came the pseudoscience, where we talked about lots of new novel therapeutic agents, homeopathy, Ayurveda, lots came into the picture. And now research. In research also came lots of controversies. Two of the papers published in one of the biggest journal of our history has been withdrawn. So everything led to lots of confusion, controversy. But we currently know the drugs which work is basically dexamethasone, the mask, and which is everyone should be aware of. Everywhere the mask, and the only vaccine which we have currently. We don't know whether in future vaccine will come or whether or not that or we have got lots and lots of illnesses, HIV, dengue fever, where we don't have any vaccines, but we are still living with it. Disease like tuberculosis, where we have vaccines, but it's not at all effective. So we should not be too focusing on vaccines, but we should focus on something else, and that is rural health and primary care. That's the most important thing, which we, from the perspective, the government side, and from the administrative perspective, we are not giving much attention to it. It's not the tiny viruses which is creating havoc. It's our weak primary health care which is letting this tiny virus to create havoc. If we had a very strengthened primary health care, if we had a good health workforce, if we had the network of young doctors, nurses, workers, effectively recruited in the rural areas, then we wouldn't have that much of severity which we currently see. We still lack the health workforce which is required in rural areas. We still lack the number of drugs, diagnostics, support which is needed in areas. And the primary care, when the patient first needs a doctor's help, they are not getting it. There is so much of stigma attached with COVID-19 that the patient, even if they have got access to hospitals, they are worried. They are fearful of going to a hospital, even it's very nearby, accessible, affordable. So there are multiple dimensions to the access issues. It's not only the access where we see the how many kilometer, how much far it is from the home, but it's also the stigma and the societal pressure, what's going around the environment, what's coming into the newspapers, media is also creating panic, and that also has led to what we call as collateral damage. We should also focus on non-COVID-19 illnesses. Because of COVID-19, other diseases like tuberculosis, HIV, diarrhea, global study the three most common causes of deaths is diarrhea, respiratory infections, other non-communicable diseases still there. COVID-19 has not reduced the incidence and prevalence of these diseases. But what COVID-19 has led is the interruption. It has acted as hurdle in supply of drugs, diagnostics, and also to access of doctor. Beyond healthcare, it has also damaged the economy. Economy has been damaged up to a great extent. We also have seen migrant crisis. People aren't getting jobs. They have to return back homes. Even if they return back homes, they don't have money to sustain a good livelihood. COVID-19 is not only a health issues. There's other social determinants of health that also we need to look into. When we are seeing a patient and we are prescribing a medicine, we should also be aware that whether the patient can buy those medicines or not. If we are not aware, then even after prescribing medicines, even after counseling the patient may not heal well. Then came, after 2-3 months of COVID-19, we came to this issue of over-treatment and over-diagnosis. Any cough, cold, we started panicking it as a case of COVID-19. All the cases of cough, cold, and fevers are not COVID-19. There are other illnesses. The most important in our subcontinent is tuberculosis. We have started doing CT scans. We have started doing lots of very high-fi tests, serum ferritin, LDH, CRP, D-dimer. These are very costly tests, and not everyone can afford it. And during the time when the economy is so much wrecked that people don't have money, and then we have got these kind of fancy tests. We are doing CT scan just to diagnose COVID-19. We are doing lots more tests are coming up. These RT-PCRs are very costly tests which patients have to undergo. Then is now coming as equity. When we talk about drug diagnostic and health workforce, the distribution of health workforce from rural urban, this disparity is also a challenge in COVID-19 times. And even when we are talking about the vaccines, whether the vaccines will be affordable to all or not, whether vaccines will be available for free or not. And what about the patents which these big giants are making? These all are some of the major issues which we need to look on. And the final thing is the metaphors which we are using in our current times regarding war and warriors. I certainly, many people might agree with war and warrior, but I certainly have some disagreement with this warrior kind of narrative. It's actually, it reduces our work. We are physicians, and our job is to take care of our patients and our society. Warrior metaphor and war metaphor is something sets a very wrong narrative, which takes away the safety, security of a physician. It also takes away the rights of the patient. And finally, whether this adversity, whether it will give some opportunities to strengthen our primary health care. If we look at the current discussion globally, whether it's about strengthening primary health care, whether they have realized that primary health care, strengthening primary health care can deal with future pandemics. I feel that people still have realized the role of primary health care. And that I feel through discussions, debates, we need to make everyone, the policymakers, aware that it's the primary health care that can help to bring down mortality. Still, we are talking about vaccines and other issues which are important, but not as important healthcare. If we look in primary healthcare, then we'll achieve lots more which are immediate. Then to rely on vaccines and other high-fi funda diagnostics and drugs. That's all from me. Thank you.
Thank you very much, Pratish Kumar. Now, I would like to call very energetic
Please
and
welcome
dynamic
John
man.
Jones, Monuddin Akhtar.
John Unjo from UK. Please welcome Dr. John Unjo.
Hi, salam alaikum, namaste, good afternoon, everybody.
Alaikum assalam.
I've been asked to speak about the Rural Miscellany blog that I've been running since March the 20th this year. I've been an observer throughout this crisis. I've researched major journals, news channels, social media, and the internet for looking for information on COVID that would have some value to rural health physicians. I've sent out 106 individual blogs, going out to probably about 3,000 plus people, and in all about 4,000 links that I've actually sent out. So these are my reflections, and these are some of the major issues that are now trending globally. I think the first thing to say, this is a global disease. To date, 39 million cases around the world. Over 1 million deaths have been recorded in 235 countries. Many countries are now anticipating, will have now got the anticipated second wave, and we will possibly be talking about a third wave at a later stage. I can't find exactly the number of healthcare professionals that have died in this crisis. Amnesty International talks about 7,000. I believe it's considerably higher than that. And there's uncertainty of the impacts of genetics and race on the people who've died. So some of the issues that I think are important, and I'm going to follow many of the issues that Pratyush has already talked about. The first is about debasing science. And that's a real worry for the future and the scientific community in the future. Papers are published without peer review, and they actually apparently appear to carry academic weight. The internet is flooded by fake news. Governments are undermining science and scientists, and we see this in the United States, where the FDA and the Center for Disease Control are being undermined on a regular basis by the White House. But we're seeing it in other countries as well. We're seeing it in the UK, where government scientists are not listened to, and I'm sure you've all got examples of that. We're seeing major journals openly supporting candidates. It's never happened before. Rather than being objective and uncommitted, they're actually asking to support major certain candidates. We're seeing a growing concern in the number of papers now that are coming out into the scientific world about the uncertainty and about concern about science. The countries coping least with the disease appear to produce most of the publications, which is very strange. And we're seeing vaccines released without testing properly in China and in Russia. And that's a very great worry for the future and for the future development of vaccines. The next point is the progress of global health. We've seen major improvements over the last half century. Millions of people have been taken out of poverty, and their lives have been improved. The quality of their lives have been improved, especially in low and middle income countries. Infectious diseases such as tuberculosis, HIV, malaria, dengue appear to be on the rise again. Immunization schedules around the world have been abandoned or missed. Progress in managing non-communicable diseases have been lost. And we must remember that more people die of these than die of COVID-19. International collaboration in health has been dealt a grievous blow, especially by Donald Trump. We don't know where we are anymore with the Sustainable Development Goals. They were doing very well, but that's actually now a concern. Now, Bill Gates, who has been vilified in the social media in an interview, said that the progress in global health has gone back 20 years. The next topic is global uncertainty. And some of these, you've already mentioned these. Will health systems cope or survive this pandemic? How long will it last? What will be the impact of seasons of flu and winter in the Northern Hemisphere, and likewise in the Southern Hemisphere? How will we defeat it? Will there be a vaccine? Will it work? Will we get effective treatments? Will life return back to normal? What will be the human and economic cost of this pandemic? And I suspect that's going to be vast. And we may well see ourselves going back to the level of the 1930s and the Great Depressions that happened. Will there be a new normal? Will we see significant social unrest and political chaos? Now, we've seen that already. I suspect we are going to see social unrest. We may well see international problems what happens to the environment? We've forgotten about the environment in this. People keep on saying, look, you know, let's remember the environment. The environment is the elephant in the corner, because actually that's progressing at a really worrying rate. So what are we dealing with? There still remain more questions than answers. We know very little about this disease, despite the immense progress that's been made. Why are some countries, some societies, why are they hit worse than others? I mean, I look at some of the figures that you've been presenting, and I'm really quite impressed by what you've achieved, but there's much, much more to this. You know, in the UK, we've had nearly 50,000 deaths. Now, you know, we've got a very sophisticated healthcare system. So why is it different in certain countries? Yes, we have an older population, but there's more to it than that, and we don't know. Why are the death rates lower in certain countries than others? And it's not just about treatment. It's actually a whole load of issues. It's a multifactorial issue. And what we can say, this is a brutal disease, and it presently has the better of us. The next topic is technology. The jury is still out on the benefits of technology. Does it really help? Are we missing other serious diseases and cancers because of the use of remote consultations? Will governments see digital health as a cheap alternative in the future rather than traditional models? And so will they kind of demand changes that are going to happen in a very different way, and we will lose the goals and the pillars of family medicine? And will this technology ever be evaluated properly? This is the first time we've introduced major changes and we haven't evaluated it. The other questions are, what is the story of long COVID? Nobody's mentioned that. And will our health system be able to cope with the long-term legacy of this disease, of countless people around the world who have been permanently damaged by this disease? What will be the impact on rural and isolated, fragile health systems and economies? When will the next pandemic happen, and how can we prepare for that? How will we train our future workforce? The next option is humanity. We have seen wonderful examples of the best human endeavors, compassion and kindness during this pandemic, local, regional, and global. But we've also seen the worst of humanity. So as I said earlier, will the pillars of family medicine appear again with patient-centered continuity of care? And finally, I'd just like to talk about equity. Will rich countries maintain the same level of international aid? What about the vulnerable, the refugees, the migrants, the poor, the elderly, the very young? Will we listen to them? Will low and middle income countries get their share of vaccines, of PPE and other resources? Finally, I teach a global health module at the university that I work at, and we have 3 guiding themes that drive global health. The first 2 appeared in the early 19th century, and they were protecting your borders, keeping your population safe. The second was protecting your trade routes, your economy, and your sources. The third, which appeared after the Second World War, and was finally adhering to the principles of the International Declaration of Human Rights in 1948, Article 12, which requires governments to recognize the right of everyone to the highest attainable standards of physical and mental health. This has driven global health for the last 50 years. I fear we may well see that retraction now, and that rich countries will revert to managing the first two, but not necessarily the last one. So thank you very much. I'm happy to answer questions. I presume we won't have enough time. If you want to email me, my email is john@johnwj.com, john@johnwj.com. And if you would like to receive rural miscellany, some of you may not be receiving that. Please let me know and I'll put you on the mailing list. Thank you very much.
Thank you very much, John, for share with us your informative and valuable speech. And thank you all very much for joining us. Now I hand over this session to Professor Dr. Zakir Rahman.
Thank you, Manuddin Haq Tushar, for brilliant moderation. And we are
Thank you, sir.
beyond our time. Very good discussion. All the panelists doing a great job with their talk. Everything there. Research question, policy making thing, or what to do, what not to do. So we have a glimpse from the South Asia and as well as rural miscellany from John and Jones. We have still waiting for Tariq Aziz. Tariq Aziz is contacted with me and he sent his presentation already. So, Dr. Tariq Aziz, do you able to join with us? So we can go for question from audience. Those you have any question for any our panelist? John is ready for to answer question already.
Please put any question you have into chat if you'd like to ask any questions of the panel. Here is Tariq. Tariq,
Yeah.
welcome. I will put your presentation up, Tariq.
Yeah.
Yeah, please welcome Tariq Aziz from Pakistan. He is the president of Pakistan
Society of Family Physicians.
College of Family Society of Family Physicians. Please join with us.
Yeah.
Bruce presentation.
Yeah. Can I start saying something?
Sure, sure.
It's coming up, Tariq. There we go.
Yeah. In Pakistan, we had increase in corona cases in late March this year. Before that, the things were quite, and nothing serious was there. But suddenly, in second half of the March, we had serious problems, and all schools and colleges and government offices, they had to be closed. So the March, April, May, and June were the months when we had a lot of problems and all public life came to standstill. And the confirmed cases in Pakistan till today are about 319,317. And till today, we have about total number of deaths about 6,600. On the average, we went at a very high scale. Daily deaths were about 150 to 200 in the beginning, in the month of March and April and May and June. But then God helped us because some sort of immunity was there because of tuberculosis or BCG vaccination or whatever it was. Then suddenly the graph came down. And right now we have about, on the average, less than 10 deaths per day. and still we have about 7 or 8,000 new cases developing, but the recovery rate is very good, and ultimately people have joined their offices, the schools are open, public transport is open, and the death rate has come down significantly. Of course, the government played a very good role. They implemented a smart lockdown. Only those areas were locked down where we could find the cases there. Those towns, those streets, those areas, they were locked. They were locked, and the people from that particular area, lot of samples were taken, and all those families, all those contacts, contact tracing was done. They were segregated, and ultimately what happened that the death rate came down, and all the hospitals which actually had a lot of corona patients, they could not find any more admissions there. So in Punjab we had more than 100,000 cases, in Sindh we had 140,000 cases, and lesser number of cases in Balochistan and KPK and other Gilgit Baltistan. So the number of patients, they declined sharply for the last 2 months, and for the last 1 month or so, all the schools, offices, public transport, everything is open. But still, we are very careful. The people are using their masks, they are using their hand sanitizers, and they are also keeping distance. In our clinics also, we are very careful. We have to keep distance with the patients. Sometimes we use glass screens in between, and we also use visors to prevent spread. Of course, we use the gowns and masks and everything, and also gloves while handling suspected patients. So right now, I rarely see a patient in a month or so, 1 or 2 patients of COVID who visit me, or I diagnose them. Otherwise, I used to have at least dozen patients every day in my clinic. So thanks to Allah, we are back to normalcy to some extent. But during the last few weeks when the schools were open, there has been increase in the number of cases. And certain schools and certain areas have been locked down again in the capital, in the frontier province, in Punjab, and especially in Karachi, in Sindh. So I suppose we are trying to keep our economy going and also trying to prevent the spread of corona over here. So the active cases has suddenly gone down with all these preventive measures, and we are eagerly waiting for the vaccine. The vaccine is available on the trial basis, which China has given to about 20,000 people in Pakistan, and they are trying to use that vaccine, and they are volunteering themselves for that vaccine. And I'm very hopeful that unless we have any serious problem, we can continue with our schools and colleges and transport, and also, of course, the medical centers, where we had a lot of clinics and wards made available for the COVID patients. Almost most of these hospital clinics have been closed down now, and very few places are there where normally patients are reporting. And there are few labs who have been authorized to carry out all these tests, and government is also sponsoring this activity. Government reaches out to those areas and carries these tests voluntarily without charging the people. So everybody comes in, whoever is suspect, so people can get themselves diagnosed and then segregated for further treatment in appropriate places. So this is a story of COVID in Pakistan. So any queries or questions are welcome. Can you hear me, Bruce?
Yeah, thank you, Dr. Taikaziz. Actually, he is now President-elect of South Asia region. So, any question, please ask any panelist. We have only one more question to speak because we are already 16 minutes uh, late for today's session. Thanks, Bruce, to allow us, and those who are already with us, being us. Thanks for your staying with us.
There is one question here, Zakur from Sharifpur in Southeast Asia, like other part of Asia, many people are living in rural areas. Many expatriate work in Middle East and other foreign countries. So rural population got more extra cash and eating more rich food. Lifestyle change, more chronic disease incidence in rural area. How to manage these increasing numbers of chronic diseases? John and other panelists, please.
John, can you answer the question or add something or comment? John and Jones.
Can you repeat the question, please?
This question is open for all. John can answer and even Tariq can answer.
It's about
can you
manage chronic disease and increasing the amount of chronic disease in a time of COVID. Tariq?
Yeah. Actually, the hospitals were the OPDs were closed during the COVID season. So they were actually directed towards very particular clinics and OPDs where they used to make sure that these diabetes or hypertensive patients or even the terminal care patients would be treated separately. But the main OPDs, especially the ENT and eye, they were all closed. We had problems temporarily for quite a few weeks, but then the government made separate arrangements for these particular patients, and they would call a particular number, and appointment would be fixed to a particular place for these patients. And those doctors who are dealing with endocrines or chronic infections, they were then pinpointed that they would see certain number of patients with all the precautions in their particular OPDs, which were opened very selectively. And only those patients were entertained who had serious problems, who required urgent help. All other patients who were stable were not given any appointments during this particular period. So they were told to use the telemedicine type of medicine, because we initiated telemedicine from our universities or from our clinics, and those telemedicine clinics were available round the clock. So they used to help these patients through the telemedicine consultations. And those who were serious, they were made to go to certain OPDs which were made corona free, and they had to take prior appointment if they had to really see a consultant there. Otherwise, telemedicine was used very frequently, and it was round the clock available from many centers.
Thank you, Tariq Aziz. Thank you all the panelists for your brilliant presentation and discussion about COVID in South Asia and rural miscellany. And I think it's a good discussion and very fruitful second day. Now I think the time.
John's got a very quick comment there, Sakura.
Sorry?
Just very briefly, Zakir, really.
Sure.
I think when it comes to rural areas, there's not a lot of information about the impact of COVID on rural areas, but it appears that rurality provides some degree of immunity, but because it's isolated. But once the COVID gets into a rural community, it can then actually devastate the health system there. But when it comes to non-communicable disease, one of the reasons that non-communicable diseases are more prevalent, or the impacts of them more prevalent in rural areas, is because they've been under-resourced and under-invested in the past. And actually the whole COVID story has just made that a lot worse. So I think when we come to managing, I'm sorry, Tariq, but actually telemedicine is not the answer to everything. Actually, if you're managing non-communicable diseases, it actually has to happen on the shop floor where people live in rural areas. And in fact, it has to have a community approach to it. It's time intensive. So it's about people actually taking control of their own lives. A big investment in community health workers, because actually community health workers and nurses can have a major impact on non-communicable diseases. So it's a lot more complex. It's about investment, but it's also about a bottom-up approach into actually managing in your own community, and rather than a top hierarchical approach. That just doesn't work.
Thank you, John. Any other quick comment from any panelist? Well, I think it's a good discussion, and the time to close the discussion. If you have any important, short, quick contribution to say it, or last message, or close it, any panelist. Otherwise, we will close the panel discussion, and we welcome you all. The third day of the conference tomorrow. It's another big day. We have a virtual rural clinic visit. It was previously planned to face-to-face visit. The COVID pandemic has a barrier in between us, but finally we have to manage you with a new style hybrid conference. We have audience with us from local audience and as well as around the globe. You all people are joining with us. Thanks for your support. And I must thank all the panelists, Dr. Nazneen from Bangladesh, Dr. Protyush from India, Dr. Gobit from Sri Lanka, Dr. Pramendra Prasad from Nepal, and Dr. Tariq Aziz from Pakistan. He managed last minute, and very welcome, Tariq Aziz. I'm a little bit afraid you have not managed, but finally you got it. So now we are very happy. All the panelists play their role, and congratulations from conference secretariat and from Bangladesh. So 17th Wonca World Royal Health Conference, the second day is about to close now, and we will get together again in same time, that is Dhaka and Astana time 4 p.m. and GMT +6. And please correlate with your time destination, because so many time in the around the globe, American, Australian, New Zealand, Europe, Africa, and South Asia. So please be correlated with Dhaka time 4 p.m. And tomorrow we'll see you. Thank you very much for all your support. Bruce, for last comment from you.
Look, thank you, Zakir. I think the South Asia panel really has been just terrific. And Tariq, it's great to see you after all these years and able to come on to this. I showed a photo yesterday of you in 1995, so I'll send it to you as a memory. So you're still looking great, and thanks to the whole panel for all your input. Rural doctors really are the crux of the solution in rural areas, and I take my hat off. I admire you so much for that. So thank you very much, team, and we'll look forward to catching up with you tomorrow at the same time.
Thank you. Thank you. Thank you once again.
Thank you.
Bye-bye.
Bye.